Hello, everyone. I hope you had a nice coffee break. I'm very happy now to welcome you to session 6 of this year's workshop entitled Special Populations in Pediatrics. My name is Tim Cressy. I'm joining you from Chiang Mai, northern Thailand. You can see it's already quite late at night, but I'm very happy to be here to this exciting session. I'm joined by my co-chair, Angela Kolbers, who's in Nijmegen in the Netherlands. And together we'll guide you through this session, which made up of firstly 3 oral presentations, and again, as we've seen for the other sessions, we'll have each presentation and by a 10 to 15 minute Q&A, and then Angela will take us through the oral posters. And with that, I think we can move on to the first presentation. This is by Dr. Veena Nikaiman from the University of California in San Diego. She's going to tell us about a study looking at the impact of CYP2B6 genotypes, TB therapy, and formulation of efavirenz in very young children.
I'm going to be talking about the impact of CYP2B6 genotype, TB therapy, and formulation on efavirenz pharmacokinetics in infants and children under 40 months of age. Efavirenz is a non-nucleoside reverse transcriptase inhibitor, which remains an important component of pediatric antiretroviral therapy. The drug is characterized by minimal drug-drug interactions, which is especially important for patients co-infected with TB, who may be on multi-drug regimens. Efavirenz has once-daily administration, which leads to ease of dosing and improved compliance. Despite the many advantages associated with efavirenz, there are challenges in dosing infants and young children. Firstly, clearance is affected by CYP2B6 genotype. The 3 genotypes are GG, GT, and TT. Prior studies have looked at giving 1 dose to the GT and the GG genotypes and a lower dose to the TT poor metabolizer genotype, but it may be that all 3 genotypes require a different dose. Different formulations exist for pediatric populations, namely solution, crushed tablets, and open capsules, all of which can affect bioavailability. Anti-tuberculosis therapy may also affect clearance, and it's unclear if age affects the pharmacokinetics. The goal of the current study was to develop a population pharmacokinetic model to quantify the effects of CYP2B6 genotype, formulation, age, and anti-tuberculosis therapy for infants and young children less than 40 months of age. Our analysis drew from 3 previously published impact studies, namely 382, 1021, and 1070. All 3 studies included HIV-infected infants and young children. 1070 had a cohort of patients who were co-infected with tuberculosis. There were 19 patients in this cohort. In total, we had 103 participants in the 3 studies used in the analysis. All 3 studies utilized sparse and intensive sampling. 1070 looked at dried blood spots in addition to plasma sampling. There were 1,202 plasma concentrations and 561 dried blood spot concentrations included in the analysis. The median dose was 400 milligrams, with a range of 60 to 700 milligrams. 80% of patients had CYP2B6 genotyping information. 3 different formulations were used in the studies. 382 and 1021 were almost exclusively solution formulation, whereas 1070 was predominantly open capsules, but a few patients received crushed tablets. We performed population pharmacokinetic modeling using nonlinear mixed effects modeling, non-mem version 7.3. Since this was a pediatric population PK model, we included allometric scaling on clearance and volume of distribution prior to the evaluation of other covariates. We used the standard allometric scaling for a small molecule, namely weight to the 0.75 power on clearance and weight to the 1.0 power on volume of distribution. In looking at the data, the dried blood spots were consistently lower than the plasma samples, so we compared the differences in the model using a scaler. The model evaluated the effects of CYP2B6 genotype, age, gender, and rifampin INH co-administration on clearance. It also looked at formulation on bioavailability. There are many different ways to look at CYP2B6 genotyping in the model. We drew from a prior publication of efavirenz, which looked at a factor of theta raised to the square root of the CYP2B6 activity score, where we defined CYP2B6 activity score as 0 if the patient was TT genotype, 1 for GT, and 2 for GG. We started with a one-compartment model, and this described the data well, so we did not pursue more complicated models. We had a separate error term for intensive and sparse sampling, and used a combination error model, which had proportional and additive components. The table shows the parameter estimates from the final model. Theta 4 was the scalar which evaluated differences between dried blood spot samples and plasma concentrations. The value of 1.23 demonstrates that the dried blood spot concentrations were 23% lower than plasma concentrations. CYP2B6 genotype on clearance and TB therapy on clearance were significant covariates in the final model, as was liquid formulation on bioavailability. Age and gender were not significant covariates in the final model. Inter-subject variability decreased from 86% to 67% from the base model to the final model. In looking at the residual error, the proportional error for intensive samples was 28% as compared to 64% for the sparse samples. CYP2B6 genotype had the greatest effect of all the covariates in the model. You can see in the equation for apparent clearance below the table, it was a factor of 3.26 raised to the square root of the CYP2B6 activity score. What this meant is that the GT genotype had a 3.3-fold higher clearance than TT, GG had a 5.3-fold higher clearance than TT, and GG had a 1.6-fold higher clearance than GT. TB therapy also had a significant effect on clearance. We were expecting the TB therapy to increase clearance due to the effect of rifampin. However, we saw a value of 0.71, so clearance was 29% lower with TB therapy, and this was predominantly due to the effect of INH. The liquid formulation led to a 42% lower bioavailability than open capsules. Our bootstrap internal validation is shown in the table. It converged 96% of the time, and the parameter estimates were well within the 95% confidence interval of the bootstrap. Here are the diagnostic plots from the final model. On the left, the conditional weighted residuals were plotted against time after dose. You can see that for plasma and dried blood spot samples, along with the 3 separate studies, there appeared to be no significant bias with time. In looking at the concentrations as compared to the model individual predicted concentrations, we can see that there is no bias around the line of unity. Therefore, the final model represents the data from the 3 studies well without significant bias. We wanted to look at how genotyping, TB therapy, and weight affected the median trough levels. And we wanted to evaluate this using the 1070 protocol dosing, so performed a simulation of the final model. Table 1 on the left shows the P1070 protocol dosing. This was a weight band-based dosing, and patients with the GG and the GT genotypes received a higher dose than those with the TT genotype. For our simulation, we looked at the 3 different genotypes, TT, GT, and GG. Patients were either assigned to the TB therapy group or no TB therapy group, and were assigned 1 of 10 weights. We had 200 subjects per genotype, weight, and TB therapy combination, giving us a total of 12,000 subjects. The dosing is shown in the table on the left, the cohort 1 step 1 dosing. Patients are assumed to be at steady state and receiving the open capsule formulation. Here are the results of the simulation. We have trough concentrations. These are the median troughs separated by weight, genotype, and the presence of TB therapy. The goal C trough is shown with the dashed lines. Trough concentrations less than 1 microgram per mil are felt to put patients at high risk of viral rebound. Trough concentrations higher than 4 micrograms per mil are felt to increase the risk of CNS toxicity. You can see with the graph on the left, there were dramatic differences between the GG and the GT genotypes. However, almost all of the median trough concentrations remained within the target range. On the left, for patients on TB therapy, those differences between GG and GT remain. However, now the majority of the GT median troughs are above the target range, as are many of the TT trough concentrations. What we've shown here is that CYP2B6 genotype TT, GT, and GG resulted in significant differences in clearance. The simulation showed that different dosing may be needed based on each individual genotype, especially for patients on TB therapy. And this is because TB therapy led to decreased clearance, likely due to the INH effect. The liquid formulation led to a decreased bioavailability. However, very few patients are receiving liquid formulation, so this may not have as much clinical relevance. Age had no significant effect on clearance. In conclusion, future pediatric dosing recommendations for efavirenz should consider CYP2B6 genotype, formulation, and the presence of TB therapy. I'd like to finish by thanking the participants and their families, the Impact Network, the 3 study teams, and funding from the NIH. Thank you all for your time.
Thank you, Mina. That was an excellent presentation. I'd just like to remind you all that to put your questions in now so you don't forget over the next few presentations. We'll get to them all, hopefully, if we have enough time. But we'll move on quickly to the next presentation is by Vera Boekums from Radboud University in Nijmegen in the Netherlands, who's going to give us a presentation on subtherapeutic raltegravir exposures in pregnant women living with HIV treated with 1200 milligrams once daily, assessed by a PANNA analysis.
Hi, I am Vera Boekums, and today I will present to you our study that assesses subtherapeutic exposures in pregnant women living with HIV treated with raltegravir 1200 mg once daily. These are our disclosures. Those of you who have been pregnant know that your body completely changes during pregnancy. These physiological changes influence the absorption, distribution, metabolism, and elimination of drugs. As depicted on this slide, a variety of physiological processes changes, making it difficult to predict the resulting drug exposure in pregnant women. From previous research, we know that the drug exposure is generally decreased in pregnant women. Decreased drug concentrations mean that the person is at risk for inefficacious treatment. In a woman with clinically relevant lower drug concentrations, the viral particle replicates and becomes detectable. Next to affecting the woman's own health, adequate treatment is of particular importance in pregnant women to prevent mother-to-child transmission of HIV. This prevents infecting the baby with a lifelong chronic disease. It's not feasible to perform a large clinical trial examining the virologic failures in pregnant women. Therefore, we evaluate the efficacy of antiretroviral drugs by measuring drug concentrations in pregnant women and base the efficacy on the exposure-response relationship. The most important parameter in the monitoring of antiretroviral drugs is assumed to be the concentration before next dose administration, the C-trough. This has to be high enough to continuously inhibit the replication of the HIV virus. In this study, we examined the pharmacokinetics of raltegravir during pregnancy. Raltegravir exists in 2 formulations. The first raltegravir regimen existed of 1 tablet 400 mg twice daily, 400 mg BID. In 2017, the raltegravir 600 mg tablets received market authorization. These tablets have to be dosed as 2 tablets once daily, 1200 mg QD. This new formulation enabled an easier and more patient-friendly regimen as a result of the less erratic absorption and decreased influence of concomitant food intake. This regimen showed non-inferior efficacy and safety to the former 400 mg BID regimen. However, a pharmacokinetic study of multiple dose pharmacokinetics in fasted states showed that the mean C-trough is 38% lower when dosed in this regimen. Theoretically, this means that this regimen is more sensitive to concentration-lowering influence, like drug-drug interaction. The former 400 mg is a preferred antiretroviral drug in pregnant women in Europe and in America because of the increasing good experience, no safety signals, and the potency to quickly decrease the viral load. However, no data exists for the new regimen. Therefore, this regimen is currently not recommended in pregnant women. Collecting data is challenging in this group because of the alternatives. Therefore, we aim to develop a POPPK model for raltegravir. With this model, we aim to predict the pharmacokinetic profile of raltegravir 1200 mg QD in pregnant women and On basis of the pharmacokinetic profile, we could discuss the expected pharmacodynamic characteristics of valtegravir 1200 mg QD in pregnancy. We started building this POP-PK model with the data of 96 non-pregnant subjects using the 1200 mg QD valtegravir regimen. The geometric mean concentration time curve of these data is shown on the left. With POP-PK modeling, we estimated the typical values of the PK parameters used to describe this curve, like clearance and central volume of distribution. We also estimated the variability in these PK parameters to access the curves of all individuals. Furthermore, we examined the patient characteristics, interacting drug co-administration, HIV infection itself, and different meal types could explain the variability between subjects. Subsequently, we added the data of 103 non-pregnant subjects using the 400 mg BID regimen to describe the typical PK curve showed in light blue. This enabled us to estimate the difference effects of the 600 mg versus the 400 mg formulation. Then we added the steady-state data of 22 pregnant women, showed in black, from the PANNA study to estimate the influence of pregnancy on valtegravir pharmacokinetics. Finally, we aim to predict the PK parameters of valtegravir 1200 mg QD in pregnancy, the gray curve. We run Monte Carlo simulations of 3,000 pregnant women 1,000 times with multi-level random effects. We repeated these simulations under 3 conditions: fasted, low fat, and moderate fat state. As a proxy for efficacy, we compared the C-trough of pregnant women on the 1200 mg QD regimen to the C-trough in non-pregnant women using the same regimen. The lower bound of the 90% confidence interval of this ratio was defined to be above 0.75. This is similar to the target established in drug-drug interaction studies by the manufacturer. The secondary outcome parameter was the proportion of individuals with a C-trough below 0.02 among pregnant compared to non-pregnant women using the 1200 mg QD regimen. This target was derived from the receiver operating characteristics curve from the pharmacokinetic data of the 800 mg once daily studies. This regimen was shown to be inferior to the 400 mg BID regimen. The final model structure is shown on the left. A 2-compartment model with first-order elimination and absorption to 3 sequential absorption compartments best describe the data. The table on the right shows the typical parameter estimates of our model. I want to point out that we assessed that the bioavailability is 21% higher in individuals using the 600 mg tablet compared to the 400 mg tablet. This is similar to pharmacokinetic studies with these tablets. We also estimated a 49% decrease in bioavailability in pregnant compared to non-pregnant women. The visual predictive check indicated an adequate model fit to the observed concentration time data. The median and confidence interval of the observations, red and blue dotted line, overlap with the simulation, the blue and red shaded areas. So, did the simulation suggest efficacy of the once-daily regimen in pregnancy? The geometric mean ratio of pregnancy-non-pregnancy was 0.51 and the lower bound was 0.41, so the lower bound was below our target of 0.75. Also, we simulated that a large proportion of the pregnant women using the 1200 mg QD regimen had a C-trough below target. In the worst-case scenario, a low-fat meal, 59% of the women had a C-trough below target. We were able to verify our modeling results with the first clinical data of the PANNA study. 2 women who were treated with valtegravir 1200 mg QD during pregnancy were included in this study. The C-trough ratios, pregnancy postpartum, of these women were 0.46 and 0.52 and were similar to our modeling results. Both women had an undetectable viral load at 3rd trimester and delivered healthy babies. To discuss, valtegravir plasma concentrations are highly variable in and between subjects, impeding model development. Therefore, we run our simulations with multi-level random effects and included parameter uncertainty. We had to assume as well that the effect of pregnancy is similar for the 600 mg as for the 400 mg formulation. Theoretically, this will be true for the pregnancy effect on the volume of distribution and elimination because the active substance is the same. However, the effects on absorptions may be different. We made the C-trough target as secondary and not primary target because of the low sensitivity of this parameter. Also, no relationship between a low C-trough and virologic failure could be observed in a phase 3 study with the 1200 mg QD regimen. So, to conclude, we estimated that the bioavailability of raltegravir is typically 49% lower in pregnant compared to non-pregnant women, and our primary target for efficacy was not met, suggesting inadequate raltegravir exposure during pregnancy. However, the clinical data of 2 cases suggests inadequate viral suppression despite these low concentrations, but 2 cases do not have enough power to conclude something about clinical outcomes. Therefore, a conservative approach restraining the use of the QG regimen in pregnant women seems reasonable until additional research confirms that a lower raltegravir exposure is clinically effective. I would like to thank Merck for sharing their data and all involved in the PANNA study, and special thanks to Elin and Teun for sharing their expertise on POP-PK models.
Oh, sorry about that. I think I was on mute. I just want to say thanks very much, Vera, again. Maybe you could lip read me. But we'll, again, if you had the questions, please put them in the box and we'll get to them after this this presentation. This is the third presentation of this session. It's by Rajendra Singh, who's going to present about the comparison of a relative bioavailability of Tivicay, dolutegravir, in neonatal liquid formulations to pediatric dispersible tablets. And again, this is a topic which I'm very close to my heart, so I'm very interested to see the data.
Hello, I'm Rajendra Singh, Director Clinical Pharmacology Modeling and Simulation at GSK. On behalf of my co-authors, I am presenting comparison of relative bioavailability of Tivicay neonatal liquid formulation to pediatric dispersible tablet. For more information on this study, I can be contacted at my email address mentioned on this slide. The development of appropriate formulation is critical for drug development in pediatrics. The age-appropriate formulation, weight-appropriate formulation, and an acceptable formulations are needed to deliver variable yet accurate dose in pediatrics. Neonate represents an unique subgroup with multiple challenges. These challenges are because of underlying complexity of pharmacology resulting from organ development, metabolic function development, etc. This can lead to altered pharmacokinetics even when compared to youngest children. This can further lead to underdosing or overdosing, resulting into loss of efficacy or safety complications. Thus, a tailored dosage form or formulation is necessary to deliver drugs to neonates precisely. My today's talk focuses on results of relative bioavailability study for 2 dolutegravir prototype formulation for neonates under development. Dolutegravir is an integrase inhibitor approved in adults as well as in adolescents to treat HIV-1 infection. It is also approved in children weighing at least 3 kg and at least 4 weeks of age in US. For pediatric subject, alternate lower strength formulations were developed for patients at least 4 weeks of age. These formulations were either film-coated tablets or dispersible tablets. Film-coated tablets were of 2 strength, 10 mg and 25 mg, while dispersible tablets were only for 5 mg. To administer dolutegravir to neonates, two lipid-based formulations are being developed. Prototype formulation A is 5 mg per ml suspension of DDG in Migliol. Prototype formulation B is 2 mg per ml DDG solution in glycerol. This study evaluates pharmacokinetics and oral bioavailability of these two liquid formulations and compares them with dispersible tablet following single dose administration to healthy participants. This relative bioavailability study was designed as single dose, non-randomized, three-way fixed sequence study with an option to add additional periods in healthy adult participant age 18 to 55 years. 3 periods in this study received either prototype formulation A, prototype formulation B, or reference formulation, which is dispersible tablet. A total of 10 mg DTG was administered either as 2 ml of Migliol formulation, which is prototype A, 5 ml of glycerol formulation, which is prototype B, or 2 5 mg dispersible tablet as reference. As shown in figure, in period 1, subject received prototype A followed by washout for 7 days. After washout, they received 2 tablets of 5 mg dispersible tablet as reference, followed by in period 3, prototype B formulation was administered. A total of 18 subjects were planned initially, but total of 22 subjects were enrolled. This slide shows demographic of the participants. The mean age in year was approximately 31. Mean weight was 79 kg. None of the participants were from Hispanic or Latino origin, and most of the participants were white. Although the protocol permitted the enrollment of women of non-childbearing potential, all 22 participants enrolled in this study were male. Moving on to result from this study, table on left shows key pharmacokinetic parameters following administration of two test formulation and reference dispersible tablet formulation. Cmax was marginally higher for glycerol formulation followed by Migliol formulation and dispersible tablet formulation. Area under curve from 0 to infinity were also comparable between two test formulation and reference formulation. All the parameters shown in this table represented as geometric mean and %CV. AUC 0 to infinity for dispersible tablet was approximately 13 microgram R per ml. For Migliol formulation, it was approximately 13, and for glycerol formulation, it was slightly higher, approximately 15 microgram R per ml. Figure on right shows concentration time profile for three formulation. Pink curve represent glycerol formulation, orange curve represent Migliol formulation, and blue curve represent mean reference dispersible tablet formulation. This slide shows comparison of test formulations with reference. The results are presented as geometric mean least square ratios and 90% confidence bound for test to reference. In column 1, PK parameters to be compared are listed, while in column 2 and 3, results from comparison of two test formulations are presented. Column 2 represents comparison for Migliol formulation, again which is 5 mg suspension of dolutegravir in Migliol. Results showed that ratios for AUC as well as Cmax are close to 1 and 90% confidence intervals are within bioequivalence range of 0.8 to 1.25. Similarly for glycerol, geometric mean ratios and 90% confidence bound for AUC 0 to T as well as 0 to infinity are within bioequivalence limit, while Cmax was higher as upper 90% confidence bound is outside the bioequivalence range, or it is greater than 1.25, which is upper range for bioequivalence limit. The comparison shows Migliol formulation has similar bioavailability to dispersible tablet, while AUCs were similar for glycerol formulation. Cmax was slightly higher for glycerol formulation as compared to dispersible tablet. To conclude, bioavailability is for 2 neonatal formulation under development, 5 mg per ml DTG suspension in Migliol, as well as 2 mg per ml DTG solution in glycerol were comparable to DTG dispersible tablet, which is approved in pediatric subject at least 4 weeks of age and weighing at least 3 kg. Slightly higher Cmax was observed for glycerol formulation. Based on the results from this relative bioavailability study, no dose adjustment is needed in neonates. Both the formulations were well tolerated following single dose administration in healthy adult subjects. Migliol formulation was chosen for further development based on the volume to be administered in neonates. Thank you for your attention.
Okay, thank you very much for that great presentation. Now we can move to the questions. I'll introduce Angela Kolbers, who is also joining us, and I think hopefully you can hear me now. We'll move with the questions. One of the first questions is, can we unmute Tim? I hope I am on mute, so we can do that. And the first question's for Mina. It's coming from David Haas. I think he's got 2 questions. Did you consider adding other genotypes that affect CYP2B6 activity?
So for this analysis, we focused on the CYP2B6 516 genotype. We also had information from CYP2B6 983. We didn't use that in the analysis, but that's a great suggestion and something we could do moving forward for the remaining analyses prior to writing the manuscript. So thanks for that suggestion.
And he has a twofold question to this. And he's also said, did you also consider the NAT2 genotype?
We did not, and I didn't have that information in the data sets that I had.
Angela?
And I think the next question is also for you, Mina. It's come from Richard Haaland. I don't think you see it in the live Q&A online. Is it feasible to genotype infants for CYP2B6 prior to treatment, or would it be more likely to begin treatment and adjust after genotyping? And a question from me as well, is genotyping a possibility at all in the lower middle income settings?
So in the study, and these study sites for the 1070 study, at least were in Africa and in India, at week 2 of the study, they did PK samples and genotyping. I guess I would say that a lot of times we can do things in studies that we can't necessarily do elsewhere. In this study, obviously they started therapy, then made adjustments based on CYP2B6 genotype. So that may be the way we have to go. As to whether it's feasible for a larger population outside of a study, I realize there may be challenges, but I think what we showed in the presentation and analysis is that it is important, especially in this age group, because of the variability in the pharmacokinetics. So every effort should be made to try to do that. And it may need to get delayed just for logistical purposes, and start therapy, and then as soon as possible, get the genotyping information.
Okay, thank you.
Okay. The next question is for Vera. It's actually for me. I was thinking that you've shown that we've seen for a long time that raltegravir is quite a hard drug to model, originally with the absorption phase and with the food effect. And you've shown that with the 1200 milligram once daily dose, it doesn't look good for pregnancy, it looks low. If you had to give a dose once daily, did you look what would be the dose?
Yeah, that's a really good question, Tim. I haven't looked at it. It would be interesting, but I guess then you should look at the.
Could you add a 400 milligram tablet on top?
Yeah, maybe we looked at if the difference for pregnant women was between 25%, and that wasn't the case.
But if you look at the C trough target, it's also difficult to achieve with the once daily 1200 milligram dose. Maybe you could simulate once daily 1600 milligram and see if the C trough target is reached. But I didn't do it so far. But that would be interesting.
Okay.
The next question is for Dr. Singh. That's a question. Oh, it's an anonymous question. Is there a plan to release the liquid formulation of DTG also for adults when it's available?
Yeah, thanks for the question. And as such, for these neonatal formulation, there is no plan for adult because partly because of the volume of lipid which will be administered. But the formulation which is for pediatric can be used in adult. Again, it's a dispersible tablet. Once you disperse in water, it will be a suspension. So that can be administered to adults.
Yeah, and I can imagine that it would be useful to use these formulations when a patient has a gastrointestinal tube or something. So
yes,
it's soluble.
Yeah.
I have a question for Mina. It's around, I mean, we're just talking about, the liquid dolutegravir. These formulations are challenging to make. And in your study, you used crushed tablets, solution, and I think open capsule. So was it, and it was unusual, I think we've only seen it with 3TC as well, that the solution was worse absorption bioavailability than the crushed tablet. Was the tablet meant to be crushed, or you just crushed it yourself?
Those were I wasn't actually part of the study. I mainly did the analysis. I think that was just what happened at the sites, and it was allowed on the protocol. My understanding was that since the liquid was worse, and there's no plans to move forward with the liquid, that it's really going to be the open capsules is what people want to do moving forward. At least that's what I've heard from the rest of the study team. But yeah, very few patients had the crushed tablets.
Well, I think people just do what they have to do. I mean, often we've seen that in the companies will say, don't crush the tablet, but people do it. And often it isn't good. Sometimes it's okay. Sometimes it's not. So I think, I was just wondering if that was a tablet that was meant to be crushed. But again, it looks like the solid formulation is probably at least better for efavirenz.
Yeah.
I've got a question for Dr. Singh. I might have missed it, but that the healthy volunteers, did they take the medications with or without food? And would that make a difference?
So they took without food. The study was designed in a way where subjects took without food.
And then neonates, would it be possible to give it with milk or?
With neonate, it is not possible to have basically. So neonate study is yet to start, but in neonate it is not possible to have a fasting condition, or the fasting condition will be kind of modified condition. So being a lipid formulation, it won't be mixed in milk, but it can be administered before after milk.
And do you expect well, you saw a little bit higher Cmax with the 2 milligram per milliliter formulation. Would you also expect that even the exposure would be higher in these children with food?
Yes. So with food, the chances of seeing higher exposures are relatively less, because dispersible tablet, the one which we use for reference, itself had higher relative bioavailability as compared to the adult film-coated tablets. But neonate being entirely a different subgroup of patients, the doses will be adjusted based on the PK. So if we are seeing relatively higher Cmax, the doses will be reduced accordingly. And the 2 ml, the glycerol formulation, that it's not the formulation of choice. We will be starting our study with migliol formulation, which has similar Cmax as compared to dispersible tablet.
Maybe I can jump in and ask Dr. Singh, about, a bit of a formulation question. Again, maybe it's not your, you didn't make the formulation, but it'd be interesting to know, because you have the dispersible tablet, and then, going from this dispersible to a sort of a liquid, and you try these two, and again, I'm no formulation expert, these two different, liquid formulations, let's say. And can you just maybe expand on perhaps the challenges of getting this drug into a liquid formulation and why you chose one of those? And for example, neonates won't complain too much if it doesn't taste very nice, but what is the taste like of these things, and it's etc. Just a bit more about the formulation.
Yeah, so in terms of formulation, the taste was well accepted, and in neonates, again, the volume will be very, very less when we administer this formulation based on their weight. So, as you mentioned, there is always challenge to develop aqueous formulation, and one of the challenge which we faced was to kind of take sub-volume out of the dispersion. So if you disperse a tablet basically in water, and if you want to take a part of that dose, then that dose was not accurate. So that's the reason we moved into these two lipid-based formulation, where one is solution, another one is suspension. And when you take a subset of volume, you are accurately taking a dose, and that was primary reason we chose this formulation for development. There are always chances of seeing some sort of palatability differences, but in adults we didn't notice any differences or anything which kind of deter us to use this formulation in neonate.
And another very quick question for you is whether you would expect to see adverse events especially of the glycerol added in this formulation in neonates, like loose stools, diarrhea.
So, since we are administering very small volume, glycerol we are not using. We will be using Migliol formulation, but both are lipid-based formulations. So yes, there may be chances of seeing it. We didn't see in adults where we administered 4 ml of Migliol formulation, 2 ml of Migliol formulation. But yeah, there is that is what we will test in neonatal study.
And maybe a very quick question for Vera. Do you really think that the concentrations are too low with the once daily dosing in pregnancy?
Yes, that's always difficult. The modeling shows that they are too low, and when we base us on the known exposure response relationship, then they are too low. Although there are some limitations to this relationship, like the C12 target has low sensitivity. So I think we have to remain cautious and say something that differs more than 25% from the results showed in the phase 3 study that showed non-inferiority. We don't know if that's still efficacious, and it's a risk to give it to pregnant women while we still have good alternatives. Although the 2 PANNA pregnant women showed adequate virologic response, there are only 2 women. So I don't think that we have enough data to say that you can use it.
Okay, thank you very much. And with this, I would like to end this session. I would like to thank all the speakers and all the interactions, all the interactive questions online. And we go on to the oral poster presentations. And I will introduce everybody at the same time, because as you have seen, all 5 presentations will be following each other. The first one will be Omar Sharif. The second one will be Hanna Kinvig. Then it will Cindy will follow, Holly Ravitsa, and Yomi George. So the first one can start, and we'll see them all. And don't forget to put your questions in online, please.
Hello, I'm very grateful to the organising committee for providing me with the opportunity to present our oral poster on the relationship between drug exposure and SVR in a cohort of patients with decompensated cirrhosis and HCV genotype 1 infection, which I'm delighted to present on behalf of my co-authors. So we know that response rates defined as sustained virologic response with DA therapy for hepatitis C remains marginally lower in a group of patients with decompensated cirrhosis compared to those with compensated cirrhosis or those without significant liver disease. And there's been a lot of identification of predictors of treatment benefit and recompensation, well described for patients with decompensated cirrhosis in terms of selecting patients for treatment, especially important in those patients who are also liver transplant candidates. As part of this study, we aim to assess the relationship between ledipasvir exposure and sustained virologic response in a cohort of patients with advanced and decompensated cirrhosis. So the pharmacokinetic analysis cohort for this study was 314 patients treated as part of NHS England's expanded access programme early on when DA therapy became available for patients with decompensated cirrhosis, and even prior to the clinical trials being published. Patients received 12 weeks of sofosbuvir ledipasvir with or without ribavirin, and as you can see, this was an advanced liver disease cohort. Just over 2/3 had Child-Pugh-Turcotte B cirrhosis, and nearly 10% had Child-Pugh-Turcotte C cirrhosis. PPI use was common at baseline. 46.8% of the cohort were receiving PPI at baseline. This was a prospective sampling cohort where 3 to 4 samples were randomly collected over 12 weeks for a PK analysis. The pharmacodynamic analysis was that I'll be describing today was predominantly related to the patients with genotype 1. So of the 314 patients, 199 had genotype 1. Again, 2/3 had Child-Pugh B cirrhosis, and 6% had Child-Pugh C cirrhosis. Again, over 40% were using PPI at baseline, which is in keeping with what is described generally in patients with decompensated cirrhosis. So we conducted a POP-PK analysis of the entire pharmacokinetic cohort. A one-compartment model was used, best described ledipasvir PK. Population clearance was 13.9 liters per hour with an inter-individual variability of 48%. Relative bioavailability was reduced by 34% in patients who were receiving PPI at baseline. In this cohort of patients, HCV genotype did not have any impact on ledipasvir exposure. So when you compare AUC in Group 1, which is patients with genotype 1, 4, 5, and 6, and then Group 2, which is patients with HCV genotype 2 and 3, there was no difference in ledipasvir exposure. In terms of impact of ledipasvir exposure on SVR, which is the important outcome of HCV therapy, with this graph it's comparing clearance, but when you compare AUC, there is a significant difference in mean AUC between patients who achieve SVR here on the right and those patients that do not achieve SVR. And when you divide out the groups by quartiles of the lipid exposure, and you compare SVR. So patients in the lowest quartile of the lipid exposure had an SVR rate of 88%, and patients in the highest quartile of the lipid exposure had an SVR rate of 100% in this group of patients with advanced and decompensated cirrhosis. We didn't find a difference in terms of SVR between patients who are Child-Pugh B or C. So thank you very much.
My name is Hannah Kinvig and I am a research assistant at the University of Liverpool. Today I'm presenting my work titled Exploring the Role of Age in Transporter-Related Drug-Drug Interactions. There is a limited understanding of pharmacokinetics in elderly patients, and with recent increases in life expectancy of people living with HIV, there is an emergent need to understand the role of age-associated changes in antiretroviral pharmacokinetics. There is an increased risk of drug-drug interactions in aging people living with HIV due to their high prevalence of polypharmacy and age-related comorbidities. This increased risk of DDIs is set upon a backdrop of limited understanding of the mechanisms that underpin transporter-related DDIs. The current study quantified the expression of the hepatic uptake drug transporter, OATP1B1, as well as measuring the magnitude of interaction between an OATP1B1 probe substrate and inhibitor in non-elderly and elderly adults in vitro. This work aimed to further understand the role of age in transporter-related DDIs and expand the knowledge base to support the management of DDIs in elderly people living with HIV. OATP1B1 expression was determined using an SLCO1B1 sandwich ELISA kit in 3 groups of cryopreserved primary human hepatocytes, non-elderly, mixed age and elderly. A suspended primary human hepatocyte transporter uptake study was conducted to determine the hepatic intrinsic clearance and the drug-drug interaction between the probe substrate and inhibitor, pitavastatin and rifampicin, in non-elderly and elderly primary human hepatocyte donors. Statistical significance between the non-elderly and an individual elderly donor was calculated using an unpaired t-test or Mann-Whitney test where appropriate. Presented in the table are the characteristics of the primary human hepatocyte donors. In graph A, you will find the OATP1B1 expression results for the 5 individual elderly donors, as well as the mean of the 5 donors. The y-axis represents OATP1B1 expression in femtomole per microgram of total membrane protein, with the x-axis detailing each elderly donor. In graph B, you will find the OATP1B1 expression results for the non-elderly, mixed age and the mean of the 5 individual elderly donors, with the x and y axis as described for graph A. We found that OATP1B1 expression in the elderly was 45% lower than the non-elderly, and this difference was statistically significant. There was no significant difference between the mixed age and either group. Graph C represents the results for the total uptake of pitavastatin in the primary human hepatocytes. The x-axis is the concentration of pitavastatin and the y-axis is the total uptake of pitavastatin in picomole per minute per million cells. The red line represents the non-elderly donors and the blue line represents the individual 8-year-old elderly donor. To date, only the 8-year-old donor in the elderly group had been qualified for uptake transporter studies, and so this experiment was limited to 1 elderly donor. There was a 42% decrease in the hepatic intrinsic clearance between the non-elderly and the 8-year-old elderly donor. However, this difference was found not to be significant. Graph D shows the concentration-dependent inhibition of total pitavastatin uptake by rifampicin. The x-axis is the concentration of rifampicin and the y-axis is the total pitavastatin uptake as a percent of the control. The IC50 was 90% higher in the 8-year-old elderly donor, and this difference was found to be significant. This study determined a statistically significant decrease in OATP1B1 expression with increased age. However, we did not find a significant decrease in the hepatic intrinsic clearance of pitavastatin, suggesting no significant alteration of the transporter uptake function with aging. Furthermore, a significant decrease in the rifampicin IC50 value was found in non-elderly when compared to the individual 8-year-old. This implies that OATP1B1-mediated DDIs in elderly adults could potentially be less pronounced in comparison to non-elderly adults. However, due to the limitations of this study, further in vitro investigations with larger sample sizes, including a wider range of substrates and inhibitors, are warranted to verify these observations. This data, alongside PBPK modelling, could provide support for the clinical management of transporter-related DDIs in older adults living with HIV. Thank you for listening.
I am grateful to the meeting organisers for inviting me to present our data. The advanced clinical trial in South Africa compared standard care efavirenz with 2 dolutegravir-containing regimens in ART-naive individuals. Dolutegravir effectively controls viral replication and is generally well tolerated. Some patients experience excessive weight gain after initiation that includes dolutegravir, or after switching to an integrase inhibitor-containing regimen. The tenofovir prodrug, tenofovir alafenamide fumarate, or TAF, has been associated with greater weight gain than tenofovir disoproxil fumarate, or TDF. We characterized associations between single nucleotide polymorphisms, or SNPs, and weight gain among advanced study participants randomized to receive TAF or TDF with emtricitabine and dolutegravir. Our methods were as follows. DNA was collected from participants who consented to genetic testing. Genotyping was done with the Illumina Infineum Mega-X B chip. We used multidimensional scaling, or MDS, to address possible population stratification. We focused on genes relevant to dolutegravir, TAF, and TDF disposition. And our outcome of interest was percentage change in weight from baseline to week 48. We also explored genome-wide associations, and our covariates included age, sex, TAF or TDF treatment, and the first 3 MDS coordinates. I will now present our study results. All 314 participants were Black South Africans. Baseline characteristics were similar between the TAF and TDF arms. There was greater weight gain with TAF, 5.8 kilograms, than with TDF, 2.5 kilograms. We started with genetic association analysis, which focused on SNPs relevant to dolutegravir and tenofovir disposition. A SNP in ABCC10 for tenofovir had the lowest p-value. We next focused on targeted analysis involving genes relevant to dolutegravir and tenofovir disposition. A SNP in ABCG2 for dolutegravir had the lowest p-value. From these analyses, we found no associations between SNPs relevant to dolutegravir and tenofovir disposition and weight gain at week 48 after multiple comparisons. We finally focused on GWAS for weight gain at 48 weeks among all dolutegravir recipients. The only SNP that reached genome-wide significance was in TMEM163, which encodes transmembrane protein 163. There was no evidence of genomic inflation. And to our knowledge, this is the first study of associations between dolutegravir or tenofovir-associated weight gain and SNPs in genes relevant to their disposition. In conclusion, we characterized associations between SNPs and percentage weight gain in advance during the first 48 weeks of ART with dolutegravir plus either TAF or TDF. There were no SNPs in the ADME genes that were significant. Among all dolutegravir recipients, a SNP in TMEM163 achieved genome-wide significance. TMEM163 SNPs have been associated with insulin resistance and waist circumference. It is plausible that it may be involved in weight gain. This association warrants replication in other cohorts. I would like to thank the following institutes shown below for their support: and thank you for your time.
My name is Holly Rawiza, and I would like to thank the conference organizers for this opportunity to present on behalf of my colleagues on the topic of Rifabutin pharmacokinetics and safety among TB, HIV, co-infected children receiving lopinavir. Lopinavir/ritonavir is widely used as first-line antiretroviral therapy for young children under 3 years of age. However, treatment options are limited for co-infected children who require lopinavir. Rifabutin is the preferred rifamycin for adults receiving protease inhibitors, but appropriate dosing among young children on PIs is unknown. We previously found that rifabutin dosed 2.5 milligrams per kilogram daily achieved adequate exposures in older children receiving concurrent lopinavir/ritonavir. However, the only study to evaluate rifabutin among young children on lopinavir/ritonavir was stopped early due to severe neutropenia. In this study, we evaluated rifabutin safety and pharmacokinetics among young, co-infected Nigerian children 12 to 36 months of age. ART-naive children first received rifabutin dose 15 milligrams per kilogram per day as part of TB treatment only for 10 to 14 days, after which rifabutin was reduced to 2.5 milligrams per kilogram per day the same day lopinavir/ritonavir-based ART was started and continued for the standard 6-month TB treatment duration. Intensive 24-hour PK sampling occurred just prior to lopinavir/ritonavir initiation at the 2-week PK visit, and again 2 weeks after ART initiation at the 4-week PK visit. At each PK visit, serial rifabutin concentrations were measured pre-dose and at 2, 4, 8, 12, and 24 hours after the observed morning dose of rifabutin. The rifabutin 24-hour AUC was determined using non-compartmental methods and compared to adults receiving rifabutin 300 milligrams daily without ART, among whom the target mean AUC was 3.8 microgram hours per mil. Clinical laboratory monitoring occurred at baseline and during 11 visits through 48 weeks of follow-up. At interim analysis, 5 children were enrolled with a median age of 18 months and weight of 8 kilograms. The median weight for age Z-score was minus 2.8 and moderate to severe malnutrition was present in all children. The median time on treatment was 6 months at analysis. Severe adverse events were uncommon. Of 171 laboratory evaluations during rifabutin, there were 2 grade 3 abnormalities and no grade 4 events. Specifically, asymptomatic grade 3 neutropenia occurred in 2 instances in 1 patient and resolved despite rifabutin continuation. In this patient, grade 3 neutropenia occurred at the 3 and 4 week visits and normalized by the 8-week visit. At interim analysis, all patients were clinically improved with resolution of symptoms attributed to TB infection, and 4 of 5 patients had achieved HIV suppression with a viral load less than 1,000 copies per mil. In terms of pharmacokinetic outcomes, the median rifabutin AUC was higher during co-treatment with lopinavir/ritonavir compared to during TB treatment only. Specifically, the median AUC during co-treatment was 4.97 microgram hours per mil compared to that during TB treatment only with an AUC of 3.27 microgram hour per mil. Further, 4 of 5 patients, 80%, had an AUC below the target of 3.8 during TB treatment alone, while only 1 was below the target during lopinavir/ritonavir co-treatment. The rifabutin concentration time curves are shown below, in which green represents concentrations during co-treatment and red concentrations during TB treatment only. In summary, among young children, rifabutin 2.5 milligrams per kilogram daily, along with lopinavir/ritonavir, achieved 24-hour AUC comparable to adults. Additionally, favorable HIV and TB outcomes were observed, and severe neutropenia was uncommon. However, rifabutin dose 15 milligrams per kilogram per day without ART resulted in low exposures. Study of higher rifabutin dosing in the absence of a drug-drug interaction, particularly among young, malnourished children, is needed. Thank you.
Hello, My name is Jomi George, and I will be presenting the preliminary results on a drug-drug interaction study currently being conducted at the National Institutes of Health, the impact of weekly administration of rifabutin and isoniazid on steady-state pharmacokinetics of tenofovir alafenamide in healthy volunteers. As a brief background, the effect of weekly rifabutin and isoniazid on tenofovir alafenamide or TAF has not been studied, which really limits the use of this regimen for the treatment of latent TB in persons with HIV who are on TAF-based antiretroviral therapy. TAF, the prodrug of tenofovir, is a substrate for the efflux drug transporter P-glycoprotein. Rifabutin is capable of inducing drug transport in both a dose and frequency-dependent manner, which could result in lower plasma TAF and tenofovir concentrations, as well as possibly intracellular tenofovir diphosphate. Our study objective is to assess the impact of weekly rifabutin and INH on the pharmacokinetics of plasma TAF and tenofovir, as well as intracellular tenofovir diphosphate. Study participants included healthy volunteers between the ages of 18 through 65, with a target enrollment of 18 people. Study design as shown in the schematic here. Participants received TAF 25 milligrams once daily alone for days 1 through 14, followed by TAF plus once weekly weight-based rifabutin and INH with B6 for 3 weeks on days 15 through 31. Serial TAF and tenofovir plasma concentrations over 24 hours were measured on days 14, that was TAF alone, day 22, which was simultaneous administration of all study drugs, and finally day 31, which is 48 hours after the third weekly dose of rifabutin and INH. We report the preliminary results from 8 healthy volunteers, 3 of whom were female, with a mean age of 31 years, and full PK data for TAF and tenofovir. The first graph on the upper right-hand corner depicts individual TAF Cmax levels for each patient, as well as the overall geometric mean concentrations by study day in the table right below the graph. Overall, there was a high degree of variability in the TAF PK, as shown by the relatively high CV% around the geometric mean. Compared to day 14, on day 22, there was a 74% increase in TAF Cmax, whereas on day 31, which was 48 hours after the third weekly dose, a 27% decrease in TAF Cmax was observed. The graph on the lower left corner compares the geometric mean exposure estimates as reported by AUC last between TAF and tenofovir by study day. TAF is shown in green and tenofovir is shown in yellow. For TAF, compared to day 14, there was an 81% increase in AUC last on day 22, whereas on day 31, there was a 34% decrease in AUC last observed. Compared to TAF, there were less dramatic changes in tenofovir exposure overall, a 17% increase in day 22 and a 10% decrease on day 31 compared to that of day 14. When we look at overall geometric mean tenofovir exposure throughout the study, across study days, the exposure ranged anywhere between about 230 to 300 nanograms per ml/hour in this study. And for reference of note, in patients with HIV, the mean exposure is reported to be 290 nanograms per ml/hour. The last graph on the lower corner, right corner, shows individual patient level concentrations at 24 hours for tenofovir by study day. The geometric mean C24 levels observed in this study were comparable to reference data, although on day 32 we can see it was slightly lower than what is described to be the C trough in patients with HIV, which is about 10 nanograms per ml. Study drugs for all participants were generally well tolerated. In conclusion, there were different effects on TAF and tenofovir PK, which was observed between simultaneous and 48 hours after the third weekly dose. Changes in overall exposure were modest with tenofovir compared to TAF. These preliminary data do not support a significant reduction in tenofovir plasma exposure when co-administered with rifabutin and INH, but it is really important to note that additional data are needed to confirm what is essentially an observation at this point in time. To date, the study regimen has been generally well tolerated, and the study is still ongoing. Thank you for your time.
Okay. thank you all for presenting. And I would like to ask Zine to unmute yourself so that we can also see you and speak to you. I've got a question. We did get quite a few questions, so we'll start quickly. I've got a question from Andrew Owen to Dr. Al-Sharif. Was it possible to estimate the minimum effective concentration threshold for ledipasvir and SVR?
Excellent question. You would be able to estimate it looking at the probability of SVR, but if one just looked at a straightforward sensitivity analysis cutoff point, I don't anticipate that ledipasvir exposure alone would be highly sensitive in predicting SVR in this population because of the interacting feature of decompensated cirrhosis, because we know that the background liver function has a big impact on SVR in this patient group.
And the second question in the chat is also for Dr. El-Sharif. It's probably because you were the first presentation, so the others, don't worry, you'll get some. Do you know if the level of decrease of ledipasvir levels with PPI use was related to PPI dose? Can a lower PPI dose mitigate this risk?
So this was mitigated as far as we are aware. Patients were advised to reduce their dose to an equivalent omeprazole dose of 20 milligrams and separate it. But again, it's important to look at the background population here. Patients with decompensated cirrhosis have a higher baseline pH than the general population and a higher prevalence of hypochlorhydria. So there may be a bigger PPI effect in this group of patients compared to healthy controls or patients without advanced liver disease.
So you wouldn't include that. Okay, thank you. Then we've got a question from Jennifer Kaiser for Dr. Hinvig. As we saw Dr. Arya's presentation earlier, would you think that measuring the endogenous OATP 1B1 substrates would provide additional evidence of a decrease in OATP 1B1 expression in the elderly without the need for a DDI study?
Brilliant, thank you for the question. I'm not familiar with endogenous substrates. However, from the presentation this morning, I do believe that they could be used to help understand these initial findings alongside, as I mentioned in the presentation, using probes, substrate and inhibitors on top of pitavastatin and rifabutin. So I think they definitely would be useful in terms of mitigating the use of a clinical DDI study. I think it would be a bit of caution with that. I think you'd really need to implement this kind of data into PBPK modeling, which I think was mentioned in the presentation this morning as well. So I think in terms of clinical DDI study, we'd get the most information about applying this kind of in vitro data into those kind of models.
Thank you very much. The next question is from Anonymous for Dr. Cindy, who says, very nice presentation. 2 questions. Could you include TMWM163 in a multivariate analysis, including baseline BMI and other factors? Is there a plan analysis including dolutegravir, tenofovir PK in comparison to weight gain?
So for the first question, in our analysis, we looked at change from baseline, weights change from baseline to week 48. So BMI is associated with weight change, so we wouldn't include it. And regarding the second question, we have another student who is looking at the change in TVF as well as dolutegravir in comparison to weight gain. So that is not part of my analysis or project.
Okay.
But we plan to look at it, yeah.
Then I think we don't have any questions from the public anymore. I've got a question for Holly Ravitsa. the proposed dose Rifabutin for of 20 milligrams per kilogram per day is for the 12 to 36 months children, I think now. Could we also go down to lower age with this dose?
Yeah, thanks for that question. Absolutely. I think, you know, these patients, these young patients, this dosing was designed for patients not on ART, of course. And so, you know, we kind of took the standard recommended dosage for patients not on antiretroviral therapy, thinking this would just be a control. And it turned out this was a surprising finding that so many of them were kind of underdosed on what would be considered standard therapy. So absolutely, I think, you know, us pushing it up to 20 milligrams per kilogram would be relevant to the younger children under 12 months of age as well, potentially, but should be evaluated as Rifabutin is used more widely.
There is another question come in the chat box from Nancy Sheehan. I hope it wasn't answered already, but I think for Dr. El Sharif, did you look at the PK-PD relationship within Ladipus VSC trough and SVR, given AUC is difficult to obtain in a clinical setting?
So unfortunately, we didn't. We may be able to incorporate it through the model. The nature of the sample collection in this cohort was collected over 40 different sites, so they had to be randomly selected samples. So we don't have Z trough levels.
Okay, I've got a question for Jomi. I don't think you went into it very thoroughly. What would be the mechanism behind the decrease of TAF on day 22nd, but an increase on day 31? And yes, did you do any intracellular tenofovir concentrations?
Yes, thank you for the question. So we are looking at intracellular concentrations of tenofovir. We just haven't completed that analysis as of yet. So that is to be determined once we've completed the analysis. In terms of the mechanism and the differential impact that we're seeing, or the effect we're seeing between day 22 and day 31, certainly the initial theory going in was that rifapentine induces PGP. So with the increase that we're seeing in day 22, certainly there is a separate mechanism here, which needs to be further looked into. Rifapentine, just rifamycins in general, as a single dose, we know that it also inhibits OATP. And so we're not entirely sure what is actually explaining this differential impact, what we're seeing between day 22 and day 31.
Well, that's nice and challenging. So we're looking forward to all these new analysis. And with this, I would like to wrap up this session. Thank you all for the wonderful presentations, interesting research you brought to us today, and also for the interesting discussions, of course. And now I would like to hand over to Dr. Kimberly Scarsey for the final session of the entire workshop. Kimberly, over to you.
Great, thanks so much. I'm Kim Scarsey from the University of Nebraska Medical Center, and it's been my great pleasure to co-chair this year's conference with Dr. Kaiser. Before closing, I have the pleasure of presenting the Best of Abstracts Award. I'm sure many of you know that here in the US, it's an election year. So it only seems appropriate that you, as the audience, also exercises your right to vote. You can vote now for your favorite abstract. You should have that option via the polling section within your on-air platform. The options that you'll see are the top 10 abstracts which received the highest scores by our scientific committee during abstract review based on a standardized rubric. So aside from our professional admiration, the winner of both the faculty and audience awards today will receive a complimentary registration to next year's conference, which was generously provided by Virology Education. Should the same abstract receive top billing from both the scientific committee and the audience, the second place winner of the audience vote will then receive the registration. So first up, I will present the scientific committee's selection based on the abstract review rubric, but please, again, take your opportunity to vote now for the Audience Choice Awards. So I think we have the slide up first. In third place, we actually had a tie with the same score on abstract review, and that was Dr. Mina Nikanjam, and her team's work on the pharmacokinetics of TB and efavirenz co-therapy in infants and children, as well as Dr. Nicholas Coutura for his PBPK modeling of long-acting rilpivirine and hepatic impairment. In second place, we had Dr. Jenna Yeager and her team's work on tenofovir and emtricitabine exposure in transgender men and women. And finally, in first place, we have to have Dr. Jin Chang Yang and his team's work on the population PK of VRC01LS in infants. So congratulations to all of the scientific committee winners. And now we will turn to the audience vote, which will obviously be a surprise for me as well. Let's see. I'm sorry, just waiting for the last minute polls to come in. I don't think I can see the same screen. Okay. All right. Well, congratulations. It looks like this year we have Dr. Mina Nikanjam again for her work with the pharmacogenetics and TB and efavirenz co-therapy. And then in second place, we had Dr. Christina Brooks from the University of Colorado. So with that, I want to congratulate all of our winners. And on behalf of the organizing committee, I want to especially say that we're grateful to all of the abstract presenters for sharing their work at this workshop and really advancing our understanding of antiviral clinical pharmacology. So on the, can you go back one slide? Not sure, there we go. So I just want to echo Dr. Kaiser's comments from the opening. I've really missed spending this week in person with all of our amazing clinical pharmacology community, and most especially catching up with you all individually, either over a coffee or the workshop dinner in New York City, or maybe even a cocktail. So although the conference did not look the same this year, I'm sure none of you are surprised because not much looks the same this year. I'm so happy that we could still come together for a few hours each day and really spend time together and share our work. I also want to give my appreciation to the members of the conference organizing committee, the academic advisory board, the scientific committee, and especially Virology Education for continuing forward and planning what I think has been an exceptional meeting, although I might be a little biased. Of course, our conference wouldn't be possible without our corporate sponsors, so many thanks to our colleagues and friends for supporting this meeting. And finally, thank you to all of the attendees for your active engagement in this conference. The discussions have gone much better than I think any of us could have hoped, so thank you for that. Now, with just a few closing business items, please note that you will get a meeting survey via email in the coming days, and we really value your feedback as it will inform next year's meeting quite a bit. Within the next week, the editors are busy putting together all of our recording from this week, and all of that content will be available within the next week on air platform via the Events Air virtual website. So you'll be able to go to the same conference website and log in with the credentials you've used all week to view all of those recorded content. Then on November 4th, you'll find all of the enduring materials from this meeting at the Academic Medical Education website that you can find on this slide. And then although we remain very hopeful that next year's conference will find us all together again in person, please stay tuned for more details on the plans for the 2021 Clinical Pharmacology Workshop. You can keep up to date on this as well as all of Virology Education's programming via their social media accounts. And then I just want to take another moment to especially thank Wilco, Patrick, Victoria, and Goda, and all of the others from Virology Education for really their tireless effort in coordinating this really successful conference, their really swift transition to an effective online format, and especially for patiently fielding all of the questions from myself as well as the other organizing committee members. So with that, I officially close the 2020 workshop on clinical pharmacology of HIV, hepatitis, and other antivirals. And I offer my very best wishes to all of you for a safe and healthy year to come. And I truly hope that we'll all be together again in 2021. Thanks, everyone.